Yeah, we are live now.
An institution dedicated to make life healthy again. We believe in creating a sustainable ecosystem for the world where knowledge is everything at Merrill Academy. We wish to empower doctors and paramedical staff with in-depth and explicit knowledge and skill upgradation. Our collaborative learning model, well-structured and specially designed programs make sure that innovation happens daily at Merrill Academy.
This is really, I'm really impressed. This is really top notch of the educational process. One thing is when you hear something, and second thing when you come and see and feel and meet all these people.
I hope we can collaborating with the Indonesian associate hip and knee surgery.
People who are pioneer in their respective field from different parts of the world to come under one roof and share knowledge is an excellent approach in carrying this medical education forward.
Academy, structure-wise, infrastructure, arrangement is very good and it's great.
I feel very proud that in India we have such a beautiful center, which is no less, maybe more than any international center.
It's very far away from my beyond.
The teaching is excellent and the organization of this course is quite good.
It's a very great place for education.
Modern facility for training and education.
I can recommend to my colleagues to come here and to feel it.
And get to, sky's the limit.
Our vision is to transform patient care through professional education to ensure that more patients live longer and healthier life. We are Merrill Academy and we believe knowledge is future.
Thank you so much, Nico. Hi, good evening, everyone. Good afternoon to everyone in the UK. My name is Nishat. I am one of the clinical specialists of Merrill Endosurgery UK. First of all, thank you very much for joining us today. Today is our second webinar of the collaborative webinar series that we started. We took this initiative to help and empower surgeons to exchange best practices amongst themselves beyond borders. And today is our second one. So please allow me to introduce our speakers today. So we have from the Indian side, Dr. Bhavesh Pradeep Paladia. He is an oncologist consultant at Thangam Hospital and Thangam Cancer Center in Tamil Nadu. He is also the first author of conference paper in ESMO, which was published in January 2013. It was named as Development of Hypernatremia on Neoadjuvant Chemotherapy in Locally and Advanced Head and Neck Cancers. He has also contributed extensively to several international journals and also publications. Some of them are as below. He also contributed to the Indian Journal of Cancer in January 2018, and also an Indian exploratory analysis study, which was published in South Asian Journal of Cancer in January 2019. Next, please. Then from the UK side, we have Dr. Srinivasan. She is a thoracic consultant at University Hospitals of North Midlands in Stoke-upon-Trent, and her scope of work involves all aspects of thoracic surgery in lung cancer, LVRS, chest wall and mediastinum, and her research interests include stem cells in the heart and lung, and she has also conducted and participated in several clinical trials with stem cells in IHD, and also is currently working on role of stem cells in COPD. She has published on the renal and splanchnic circulation on CPB, stem cells in IHD, and chest wall trauma, and her clinical interests involve lung cancer, VAT surgeries, and robotic thoracic surgery. Then we have, from the Indian side again, Dr. Saravana Rajmanikam. He is a consultant surgeon at, again, Thangam Cancer Center in Namakkal, India, and is the chief of Thoracic Oncology Division. He has, till date, performed more than 100 VATS procedures and also performs endobronchial ultrasound for staging lung cancer. And the center is also a referral center for video mediastinoscopy. He's also very active in teaching and has conducted 4 workshops for novice VATS surgeries in Tamil Nadu, which includes didactic lectures and also live demonstration of VATS procedures. His clinical interests include the molecular framework of the Indian lung cancer, the vision-first approach of malignant pleural effusions, uniportal VATS lobectomy and benefits to the patients, pulmonary mesothelioma, and also post-chemo radiation response in esophageal cancer in Indian patients and early radical thymectomy in myasthenia gravis. Welcome, surgeons. It's a privilege to have you all here. Thank you so much for participating. And I would like to hand over now to Dr. Saravana. Please, could you kindly take the event forward? Thanks.
Welcome everyone to this meeting. I first of all thank Merrill Academy and Merrill Endosurgery Division for taking this initiative to encourage education and teaching in thoracic tumors. Not much of interest in that. I hope this streak continues. So let me not waste any more time. I'll be speaking on thymic tumors, the Indian perspective. Thymus is an immunogenic organ. It's a primary lymphoid organ in the human body. It's located in the anterior mediastinum. You can see this is a nice depiction of the location of the thymic gland as well as the areas in which thymic rests of tissue may be located within the anterior mediastinum. So traditionally, when we teach surgical residents, we talk about 2 thymic lobes, and then you have the horns, superior horns on both sides, the right and the left, and the inferior horns. Superior horns being more narrow and the inferior horns being wider, and then which conglomerate into the fat. Thymic epithelial tumors are rare tumors. In fact, it does not find mention in most cancer registry data, even in our country. From what we know from data that has been published in India is that it's rare, with about 1 to 2 cases per million population. And it consists of about 50% of all mediastinal masses. Now, I would like to mention here that we are not going to talk in this lecture about lymphomas and germ cell tumors, which form the other half. However, this group of tumors, which are however rare, has great interest in the international community, and it is well researched, and treatment strategies are well put forward in literature. And there's huge potential for cure if appropriate treatment is given to these patients. So by definition, thymic epithelial tumors are tumors of the anterior mediastinum originating from thymic tissue, and with normal germ cell tumor markers, with no evidence of widespread lymphadenopathy, that is ruling out lymphomas, and no continuity with the thyroid gland, because thyroid sometimes you have mediastinal extension or individual rests of thyroid tissue within the mediastinum. So when we evaluate a patient of mediastinal mass, this is what we do. We want to rule out these group of tumors. So the blood workup will include a CBC, platelets. We do the germ cell tumor markers, which are beta HCG, AFP, and LDH. Pulmonary function tests and a 2D echo, especially because if this patient turns out to be a surgical candidate, we are going to be working just right on the heart. So we need to know the cardiac status in these patients. A CCT thorax, that is a CT, computer tomography of the thorax, forms the major, most important investigation that we use for evaluating the mediastinum. Of course, we have FDG, PET, as well as MRI in select situations as modalities of evaluation. So when we stage a patient pre-surgically, we usually, the goals of staging are, to identify whether these are benign or malignant tumors, whether the candidate is a surgical or a non-surgical candidate. If there is any inclination that the tumor is of a germ cell or a lymphoma origin, they go on a different strategy. And if they are a thymoma, which is the topic of interest today, thymic origin tumors, you need to know whether it's a thymoma or a thymic carcinoma, because prognosis and treatment schedules differ. So like I mentioned, the most common investigation that we do for evaluation of thymic malignancies are the CT scan. You can see a small hyper-intense lesion on contrast over here. And you can see it is more dense than the surrounding thymic fat and the tumor over here. So this is T1A, which is well within the capsule of the thymus and within its boundaries. So what happens if it just expands a little more and touches the surface of the lung? Here you can see this is a mediastinal pleura, and a CT scan or an MRI cannot identify in sure whether you have infiltration of the mediastinal pleura, but whereas abutment is there, you can see a little larger tumor and bulging into the pleural cavity. This is a T1B lesion. So you can see that there's a loss of surrounding mediastinal fat at one border. Then you go to the more advanced lesions, T2. These are the lesions which are most commonly seen in our country. So T2 lesion, you can see a larger lesion, and you can see a rim of pericardium over here and abutting pericardium with possibility of an involvement. You can see a lobulated structure over here, and you can see, once you see lobulations in a thymic lesion, you can be sure it's of a different category. It's not the benign category or low risk category. It'll be more of a high risk situation. And then here you can see a tumor which is going and abutting the mediastinal, and doubtfully, you can see that probably the pericardium is involved in this lesion. When you look at T3 tumors are, in the recent classification, they have been named as tumors which invade local structures, but however does not deem them unresectable. So you can see in this location, you have a thymic tumor which is going into the superior vena cava over here, forming a tumor thrombus. Another lesion where you can see the main PA over here, and it's just creeping in through the pericardium into the main PA. And the last variety, which is T4, you can see obviously these tumors are quite extensive, and here you can see almost loss of water, fat plane with the pulmonary artery over here. Most cases it would be either abutment or invasion into the wall of the pulmonary vessel. And you can see here infiltrative lesions which are going around the bronchi and the trachea. And these are usually unresectable lesions or T4. That is what criteria we mentioned. The lymph nodes are usually stratified as N1, group of lymph nodes, which you can see in this shaded region over here. These typically are seen in front or the anterior aspect of the mediastinum, whereas the N2 lymph nodes are somewhat similar to the nodal stations that we use for the lung cancer, as mentioned by the IASLC group. You can see this purple region is the region of the N2 group of lymph nodes. And obviously M1A is drop metastasis to the pleura. You can see pleural metastases over here, which are showing a convex pattern on the mediastinal pleura, on the thoracic pleura and the mediastinal pleura over here. And M1B, where there's widespread metastasis, you can have metastasis within the ipsilateral lung, opposite lung, or the other solid organs of the body. MRI plays a special role in differentiating thymic cysts hyperplasia and thymic tumors, because many times we need not operate on cystic lesions. It avoids unnecessary thymectomy in these patients. In advanced cases, when there is a inclination on the CT scan to identify if you want to know if the vascular structures are involved or there's chest wall or nerve involvement you want to identify, then MRI plays an important role. You can see over here in this situation, a CT scan, there's doubtful invasion into the pericardium, whereas when you do an MR, you can see that there is penetration. You can see the black in a T1 weighted image with contrast. You can see that the black line over here is being infiltrated by the tumor, which is going into the pericardium and touching upon the PA. PET-CT helps in certain cases, not in all cases. Most resectable thymic tumors, if they are localized to the thorax, need not have a PET-CT scan, but there are certain locations where we use a PET-CT scan, and it usually helps in differentiating low risks and high risk subtypes, which I'll be mentioning later. It's valuable in select cases where R0 resection would be deemed difficult as part of a thoracic multidisciplinary board meeting. And in select patients for induction of chemo regimen, I'll show you to data why. We have an excellent article by Dr. Nilendu Purandre from TMH or Tata Memorial Hospital Center, who has a very nice paper suggesting the difference between a PET scan can make in a lesion which is quite advanced, and it helps us decide on whether to go for induction or go for upfront surgery. You can see over here a high risk lesion with a SUV max of more than 20. It turned out to be a B3 type of lesion, and you have a lesion where the FDG uptake is a little low, 4.1. And sorry, this is a type C and this is a type A. So FDG PET can give you a guide as to selecting these patients for induction treatment or a surgical modality of treatment. You can see the higher the risk category, you have a higher SUV value, and the cutoff in thymic tumors seems to be 6.5, at least in Indian patients. However, there's no correlation between PET-CT scan and stage. So just because a tumor is large doesn't mean that a PET-CT scan will help. More useful are in the situations where you have infiltrative lesions which are abutting structures and permeating into different planes, where a PET-CT scan would be useful. Of course, it's also useful in identifying metastatic disease. So when do we do a biopsy in a patient with thymic tumor? Most often in a thoracic tumor board, resectable lesions which are confined to the pleural surface, to the anterior mediastinum, we do not perform a biopsy in most of these patients. Only in unresectable, advanced or metastatic situations where we would recommend biopsy. And if at all we are doing a biopsy, a core biopsy is recommended rather than an FNA, preferably a 19 gauge needle, and 3 cores minimum, because you need to do quite a few immunostaining, immunohistochemistry stains to identify the exact variety, because that would guide on your further treatment. It's preferable not to violate the pleural cavity. So sometimes we get patients where the needle has passed through the pleural cavity, through the lung into the mediastinum. So anyone who's in the crowd doing biopsies, I would suggest, try to find a plane to get the biopsy which does not violate the pleural cavity or lung tissue or other tissues, because they are bound to seed. And you have this this staging system which you can all look over later with the NCCN guidelines, which I mentioned just in the pre-op staging. So these, it stages patient according to the T, N, and M stage. However, by far the surgeons as well as the oncologists look at this staging system, which is a pathological staging system, which was put forward by the WHO in 2015, where we categorize thymic tumors into A, AB, B1, B2, B3. Now, because this is a mostly surgical lecture, I'll not go into the pathological details, but immunohistochemistry, plays a great role in differentiating the different type of tumors in this. So you see epithelial varieties are A and B, and more of lymphocyte varieties are the B1, B2, and B3 types. And these are the immunostaining, especially with TDT. These are the different types of tumors according to the classification by the WHO. So you must remember that there is a type C, which is thymic carcinoma, and you have various types of thymic carcinoma starting from squamous, basiloid, mucoepidermoid, clear cell, etc. So neuroendocrine tumors as well. And these are tumors which have poor prognosis, and we need to know this before we consider surgery for these patients. So in general, this is the algorithm. A thymic tumor, if it has predominantly lymphoid component, then, if you look at if the epithelial density is more, it goes towards a B3. If the lymphoid density is more, it goes towards a B1. More epithelial density, worse prognosis. If the lymphoid component is very sparse and only epithelial component is there, then you consider a B3 or a carcinoma, and sometimes you get these neuroendocrine tumors. And because pathologists are now identifying more and more neuroendocrine tumors, we see in our day-to-day practice more and more NETs being detected, which were previously mentioned as thymomas. So let us go to the world data. You can see over here, European data mostly focused on the B1, B2 category, whereas in Asia, we have more of B3 variety. When you look at those who had surgery, you can see that, even though the Asian community had more of B3, Asian surgeons seem to be more aggressive in resecting these. Of course, these data does not include India. India was not included in the collaboration of this data. So you can see Asian population, especially Southeast Asia, like Japan, Korea, China, they have more of B3 variety of tumors, and they are more aggressive in their surgical approach. So we have one paper from the All India Institute of Medical Sciences, which looked at about 219 patients who underwent surgery. And in India, we seem to have more of, a B2 category and an AB category of A and a B2 category form the most type of tumors in the Indian subcontinent. 50 to 60% of patients present with paraneoplastic syndromes, mostly being myasthenia gravis. I'm sure the next speaker will speak on the paraneoplastic syndromes. And B1, B2, and B3 occur in younger individuals in our country, almost 10 to 15 years younger than the European and the Asian data that is mentioned in the ITMIG data. So there's no predilection for myasthenia gravis to any subtype. If you look at the Indian data, like I said, A and B2 form the greatest population. You have high volume centers in India showing these data. And let us come to surgery. Surgical methods, mostly when we look at surgery, even now in India, more than 60 to 70% of surgery for the thymus is undertaken via the open method. So you can do it via midline sternotomy, which is the most common. Some lateralized tumors are still performed using a thoracotomy. Then in bilateral large tumors, where you have to go on both sides, a clamshell thoracotomy is useful. MIS is fast catching up. Most of us who are focused in treating patients with thoracic malignancies are doing minimally invasive surgery by VATS, robotic, subxiphoid, or transcervical. So this is the open method. Open still, even now for extended resections, in this case, you can see a SVC being replaced by a graft. In extended resections, still, I think sternotomy is the way to go. However, there are situations, most of, in my personal practice, many patients are women, and, doing a sternotomy in them in young females, especially, VATS, which is done by 3 small incisions and taking out the tumor through these incisions. It's, it's a very good option. And especially in myasthenia, we do bilateral VATS sometimes if we can't go on to the opposite side. That's also an approach. There is an interesting group in Poland, Dr. Zielinski's team. They perform extended cervical resection. In fact, they do a transcervical excision of the entire thymus and the thymic tumors by putting a retractor which elevates the entire sternum up, and they use video to assist in removing the tumors. It's a very novel approach, and robotics are fast catching up. We have quite a few centers in India performing actively robotic surgery for thymus. So this is one of the papers which has completed almost 30 to 40 cases using a subxiphoid approach rather than a lateral approach for thymic tumors. And when we resect thymic tumors, it's always wise to depict them in a proper manner and send it to the pathologist so that they can know to identify margins. You need to ink particular margins so that you have staging data to guide further treatment. So how are most thymic tumors staged? They are staged by the modified Masoka staging system. Most of you would have heard this. This is a surgical staging system. Only after removal of the specimen, you can stage patients according to this. So it's divided into stage 1, 2, 3, and 4. I'll not go into the details because you can go look into it later. If you look at the world data, this is French, Japanese, and the ethnic cohort. You can see predominantly most tumors are stage 1, blue being stage 1. And then you have stage 2, stage 3 being the next common, and the others being less frequent across the board. So what happens in India, we do have the same situation. However, we have a little more of stage 2s compared to stage 1s. And then the others are less frequent. Myasthenia gravis, yes, it's a common scenario in our country as well. And especially after the publication of this trial, which showed quantitative improvement in symptomatic scores of myasthenia gravis and the reduction use of steroids and immunosuppressants, it's become quite popular. I'll not go into detail because the next speaker will be touching upon it, but I'll just give you Indian data. This is a table showing a recent publication showing the percentage of patients in our group. It's quite biased because it depends on the referral pattern of each high volume center. And you can see it varies between 9% to almost 50% the presence of myasthenia gravis. But when you look at, this is from an institution which purely looks at, it's a very high volume myasthenia gravis center. It's a neurological center, in fact. And when they looked at their 10 years data, they found that, 34% of their patients with myasthenia gravis had a thymoma, and more than 48% had a thymic hyperplasia rather than a thymoma. And this was their 10-year surgical data of 184 surgical patients who underwent surgery. And they found that around 61% of patients, more than 2/3, observed some benefit with thymectomy, and 30% had a complete stable remission. That means, totally were devoid of the use of drugs following the procedure. So myasthenia gravis can be almost negated in 1/3 of the patients undergoing thymectomy. So what are the outcomes as looking at survival data? You can see, in stage 1, we have excellent survival data even from Indian centers, ranging from 95 to 90 plus. When you go down, as noted in other data, it goes down. This is important because we need to know that very less surgeons in India perform radical dissection for thymic tumors, and the T stage depends on the recurrence pattern. The higher the T stage, the chance of recurrence is higher. And so as surgeons, we tend to send them for adjuvant treatment. And the overall survival also depends on the T stage, irrespective of the nodal status. So T staging is very important, and we need to know this even before surgery to identify which patients we are going to resect. And it helps in guiding further treatment as well. This is another high volume center, which it's a tertiary cancer center, which has very good, overall survival. They had an overall survival of about.
It's 15 hours.
Okay. So to conclude, thymic epithelial neoplasms are rare, but there's a very high potential for cure, and methodical evaluation and treatment options are available for this rare disease. And I'm sure the next speaker will highlight on how to treat these patients with surgery. Over to the next speaker. Thank you.
Hi, apologies to interrupt. Thank you, Dr. Rajmanikam. Can I please request all the members of the audience to post any questions that they may have within at any point in time, to post them in the chat box, and hopefully the surgeons will answer them in our segment 4, which is the panel discussion. Thank you. Over to you, Dr. Srinivasan.
Hello, can everybody see my screen?
Yes, we can.
Yes. Hello, everybody. Thanks very much for having me. This is a very, very great initiative that Merrill have linked up with the UK and this is the second webinar we are having. The previous speaker, my predecessor speaker, has highlighted about thymic tumors and how we classify them. I'll try to take it forward. Staging of thymic tumors by Masuoka Koga staging, which was initially published in 1981 and then again revised in 1994. This was based on a very few number of patients, about less than 100 patients. And this was on post-resection specimens. Even though we use it regularly, there are limitations, as in we get to know how the outcome will be only after the specimen has been resected. So the IASCLC undertook a thymic project where they, with the help of AJCC and UICC, have put together a TNM staging, which is now gone on to the 4th edition. This advantage of this is a pre-treatment clinical staging, and also this put along with the histological staging will give us prognosis. So basically, staging for these thymic epithelial tumors will be tripartite, either depending on the site where they are, which organs they're involving, the TNM staging and the histology put together. So from the Masuoka Koga staging, which most of you will be familiar with, which is stage 1 and 2A and 2B, have now been grouped together into TNM stage 1, where the tumor, TNM stage 1 in the TNM staging is all tumors, which is including the pleura. If the pleura is involved, they fall into stage 1. So in Masuoka Koga staging, if the mediastinal pleura was involved, it fell into stage 3. And the pericardium was also included in stage 3. So now the pericardium is considered a stage 2, but in the TNM staging, and T1 is all others, including the mediastinal pleura. They have divided that into resectable mediastinal structures and non-resectable mediastinal structures to 3A and 3B. And then T4A and T4B is similar to Masuoka Koga staging, but N1 nodes have been included in stage 4A, and the N2 as well as distal metastasis in stage 4B. That will dictate the first line of treatment, whether surgery or neoadjuvant chemotherapy. Now, the advantages of this are we have got an increased proportion of patients in stage 1, so more patients for resection. There is some stage 2, 3 patients have been downstage to stage 2, and they might need radiotherapy. Better stratification of stage 3 for surgical indication like resectable and non-resectable, and there is a better stratification of lymph nodes N1 and N2, which would impact on treatment as well as survival. So before the TNM staging, there wasn't a lot of emphasis on lymph node dissection in thymomas. Now, this you have seen already, the different types of tumor, A, B, B1, B2, B3, and C being thymic cancer, which is also neuroendocrine tumors, non-thymic acute tumors are all epithelioid. So the WHO classification, the 4th edition, has taken into consideration about 6,000 cases and all thymic epithelial tumors, and this is a worldwide database. There is all the tumor types can behave in an aggressive manner, and as of the 2015, the change in the thought process is thymomas were initially considered as benign tumors and thymic carcinomas are aggressive tumors. But now no tumors, no thymomas are considered as benign. So it is just a different histological type, and all thymomas basically should be resected from the surgical point of view. Now, there was a new term introduced, an atypical type A tumor, which has got type A cells. So we would be expecting it to behave like a benign tumor and probably encapsulated, and resection is all you need to do. But these atypical type A tumors, even though they have got type A cells, they're more aggressive, and that is classified by hypercellularity and increased mitotic activity and necrosis. So necrosis in itself correlates with advanced stage of tumor, and also correlates with more metastases. The distinction between B3 and C type of cells can be very difficult, and hence patients who are classified as B3 may be a type C. Also, Dr. Rajamanikam has already mentioned this about the lymph nodes. So N1 is the anterior region, the anterior mediastinal and anterior cervical, and the middle mediastinal and the deep cervical, as well as the internal mammary nodes, are considered as N2. Now, with thymoma itself, as we have been doing over the years, we do not give too much of importance to dissecting out lymph nodes, but we have to be aware that about 2% of the thymomas, there can be lymph node involvement, and thymic carcinomas and the peanut cancers, which would be about 27% involvement of the lymph nodes. The lymph node dissection, the biggest limitation of minimally invasive VATS or RAT surgery is that lymph node dissection is quite difficult. As you can see, the deeper regions in the N2 might be difficult to get to by minimally invasive. So the lymph node dissection, the three areas of lymph node, the perithymic, anterior mediastinal, the N1 and the N2. The perithymic usually comes along with the resected specimen, and the anterior and the lower anterior cervical lymph nodes are also dissected out usually, but the deep regional lymph nodes, they are optional, and unless it's a thymic carcinoma, you don't pursue them because there is a lot of comorbidity associated with that, with nerve damage and the thoracic duct damage, etc. There are many paraneoplastic syndromes that are associated with thymoma. The commonest being myasthenia gravis, but there are some others and which are quite significant, which is aplastic anemia, pure red cell aplasia, and Good syndrome with agranulocytosis. So occasionally the patients present with repeated infections, and if there isn't a clinical reason for multiple infections in a young patient, we should consider that they might have a Good syndrome. And we ran a series in one of the previous hospitals where I was working, and we found that nearly 5% of the patients who actually had a resected thymoma had previously had multiple infections, and which went totally undetected. And when obviously we ran an immunology project and looked at all the cases and found out that a high level of index of suspicion might have actually pointed to this syndrome earlier. Now, Lambert-Eaton syndrome, where without a thymoma, the patient has got all the features of myasthenic syndrome, cerebral degeneration, encephalopathies, sensory myelopathies, and there is also a significant incidence of extrathymic malignancies in, and that is increased in patients with thymoma. This is an interesting paper that was published recently. Now, myasthenia gravis, I will touch upon these topics, the incidence, clinical symptoms, and the role of acetylcholine receptor antibody titers, as well as post-operative myasthenic crisis. It is a rare disease, 7 to 20 every 100,000. The age group, the common age group is females at a younger age at 28 years average, and males 42. 15 to 20% of the patients experience myasthenic crisis within the first 2 years of their diagnosis. Mortality is decreased from 50 to 80% about 50 years back. It has decreased to about 2 to 2.5% in myasthenia gravis, and about 4.4% if the patient suffers a myasthenic crisis. Myasthenia gravis in the long term survival rates, patients with hyperplasia have got a better survival than benign thymoma, better than atrophy and malignant thymoma. 10 to 15% of myasthenia gravis patients have thymoma, and approximately 30 to 35% patients with thymoma have myasthenia gravis. Now, myasthenia gravis can be classified. In 1997, the American Society classified that in 5 classes. Class 1 was the straightforward with ocular muscle weakness and may have difficulty closing, weakness in eye closure, but all other muscle strength will be normal. And class 5 is patient is needs intubation, is dependent on mechanical ventilation, and might need a feeding tube, cannot swallow, those kind of patients. But class 2, 3, and 4 divided into class 2A, 2B, 3A, 3B. So the 2As, 2As, 3As, and the 4A is predominantly affecting the limb, axial muscles, and or both. And 2B predominantly affecting the oropharyngeal respiratory muscles, so and or both. So basically, as surgeons, the 2B, 2B, 3B, and the 4B are the ones we would be more worried about as patients who have got bulbar palsy preoperatively, affecting the oropharyngeal muscles or the respiratory muscles, can prone to have myasthenic crisis and complication in the post-operative period. So management of myasthenia gravis, if it is class 1 ocular myasthenia gravis with no thymoma, there is no benefit of surgery in these patients. Usually when I counsel patients for surgery with thymoma, I tell them clearly that there is a 1/3 chance of complete resolution and the medications being stopped, and there is a 1/3 chance of decreased medication but still needing some, and 1/3 of the patients will have no benefit, as has already been mentioned by Dr. Rajmanikam. Now, with newly diagnosed myasthenia gravis, they should be treated with medically till the symptoms are stable before we can consider surgery in them. So the drugs that we can use is acetylcholine esterase inhibitor, immunosuppressants, steroids and non-steroidal like azathioprine, and a few others, plasmapheresis, immunoglobulins, and immune modulators, right, rituximab and eculizumab. Now, surgery would be the treatment for myasthenia gravis, definitely if thymoma is present, and definitely if it is one of the advanced kinds of myasthenia gravis. So it'll be more patients who have got myasthenia gravis, who have had treatment with the first line of drugs, which would be steroids. And when we are increasing the dose of steroids and their symptoms are not coming under control, or we have already introduced a second line of drugs and still the symptoms are progressing, or they do get controlled, but then there is a relapse of the symptoms. So in those kind of patients, definitely surgery, even in thymic hyperplasia, with or without thymoma, and if there is a thymoma, definitely surgery would be indicated. The role of advanced treatments. Now, this one is acetylcholine receptor antibody titers. This is not done in all centers. Only a few centers and a few neurologists believe in doing these antibody titers. But if it is higher, the patients have been found to have myasthenia gravis after resection of thymoma. So, there are three different ways of resecting a thymoma. So I will be alluding to that later on. So if it is a simple thymoma, stage 1, and we are resecting a well-encapsulated thymoma, there is a tendency among certain surgeons in the surgical community to only resect the thymoma, so thymomectomy only. But there is an incidence of myasthenia gravis developing later, as there is some thymic tissue left behind, acetylcholine receptor antibody titers will kind of give us an indication that we should do an extended thymectomy, as in not only the thymoma but also the rest of the thymic tissue in the mediastinum. Plasmapheresis is reserved for class 5 patients. These are the patients who need intubation and mechanical ventilation. They might have already suffered a myasthenic crisis or presented with a myasthenic crisis. So plasmapheresis is reserved for these patients, and sometimes the antibody titers, they give us an indication as to whether the patient will benefit from plasmapheresis or not. The postoperative myasthenic crisis can happen, and that usually is defined by rapid deterioration in respiration within 24 to 48 hours, and patient needing intubation and ventilation. This can happen in patients with symptomatic stage 2 and above, patients with myasthenia gravis newly diagnosed within about 12 months, and patients who develop postoperative pneumonia after excision of the thymectomy or thymoma and thymectomy. And transternal thymectomies, there's more chances of getting post-operative myasthenic crisis than VATS. So this is the latest guidelines. Dr. Rajamanikam has already alluded to this, and I'm looking at the management side of things. So he was discussing the staging. In mediastinal mass, these are the evaluations we'll be doing, and we have already looked at that. If the thymic tumor is likely, then we will carry on and go to the next slide. If the thymic tumor is likely, is it surgically resectable or surgically unresectable? If it is surgically resectable, then total thymectomy and complete excision of the tumor. If it is locally advanced, then we'll have to consider a biopsy, core biopsy, to look at the histology, and also to give neoadjuvant therapy. So pathological evaluation after resection. So this slide gives us the indication to go towards surgery, and after resection, if it is an R0 resection, these patients, they do not need any if it is stage 1 and it's an R0 resection, these patients don't need radiotherapy. So we don't refer them on to the oncologist. Now, if the capsule is invaded, as in Masoka Koga stage 2 to 4, then they are referred for postoperative radiotherapy. And if it is an R1 resection, so the primary aim of any surgeon, whether you do it by VATS or by transsternal approach or by RATS, would be to get an R0 resection for any thymoma. So if there is an R1 resection, straight away they have to be referred to the oncologist for postoperative radiotherapy and chemotherapy, and depending upon whether it's a thymic carcinoma, and there might be a good reason why there is an R1 resection. It could be because of the tumor involving any of the structures which could not be resected out. And it could be a macroscopic R2 resection. Again, it is definitive radiotherapy and chemotherapy. And Dr. Palladia is going to discuss more about these treatments. Locally advanced tumor, we would be referring them to the oncologist, and if they are potentially resectable, chemotherapy first, followed by surgery, and obviously they have to be staged again before they can be subjected to surgery. So after the second staging, with the further CT PET and a chest CT and a CT PET, we would decide whether they are resectable or non-resectable and take it from there. So there's a clear-cut indication for role of surgery in thymomas, which is stage 1 and stage 2. Anything above stage 2, we'll have to discuss the multidisciplinary team, and that's what we do here. So invariably what happens in UK is there is a pathway where when a CT scan gets done and there is something abnormal in the CT scan, whether it is to do with lung cancer or whether it is suspected lung cancer or a mediastinal tumor, they get referred to the lung cancer MDT. And from there, we discuss the patient. Stage 1, stage 2 do not come back to the MDT. They get referred to the surgeon, and that's the end of that. But more than stage 2, then where we have to have a joint approach with the oncologist. They get rediscussed back in the lung cancer MDT and referred back to the oncologist once the resection is done, or they undergo new adjuvant and then get referred back to us. Now, the already mentioned transpleural biopsy should be avoided. Myasthenia gravis should be controlled before surgery, and the goal for resection is R0, and all contiguous and non-contiguous disease should be resected. So if a patient has got a tumor which is actually contiguous with the lung, as Mr. Rajmanikam was showing his scans, then and if the tumor is inseparable from the lung, we would go and take a wedge of lung out. It is very rare that you would do an anatomical lung resection for a thymoma, unless the majority of the thymic tissue is in one hemithorax or the other hemithorax, and it is less in the mediastinum and more in the hemithorax, then you would end up and is involving the lung, then you might end up doing an anatomical resection like a lobectomy, but that is an undertaking we don't need to do usually. A wedge resection is enough. Whichever contiguous disease, if it is involving the pericardium, which is involving the diaphragm, any part of the superior vena cava, superior vena cava and the innominate vein, and the innominate vein can be sacrificed and may not be reconstructed, but superior vena cava definitely needs to be reconstructed, and it is either reconstructed with a bovine pericardium or with a graft, as was shown by Dr. Sharavana Manikam. Now, it is a good practice to, after resection of the thymic tissue, to examine the pleural surfaces, because if there is any drop metastases at that time, we could do a resection of that straight away. Nowadays, with the advanced CT scan, CT PET, usually this kind of information is picked up even before the patient gets on the table. The one golden rule of minimally invasive surgery is, if all the oncological goals can be met by minimally invasive, as you would achieve by doing a sternotomy, then we can go with minimally invasive. Otherwise, we should choose for the gold standard, which is a median sternotomy and resection. So these are the different surgeries that can be done for thymectomy. So it's complete removal of thymus, or thymomectomy, which is a section of the tumor within thymus gland, and this leaves some of the residual thymic tissue behind, or a thymectomy, which is an extended thymectomy, including all the tissue right from the brachiocephalic vein down to the diaphragm, and from phrenic to phrenic. So there is no consensus opinion. So this was quite discussed in the ITMIC meeting in 2018, and there is no consensus opinion as to which would be the ideal operation to do in a patient with a thymoma. Now, but it is generally believed that if somebody has got a thymic epithelial tumor, it should be resected with surrounding thymus and all the fatty tissue in the anterior mediastinum. There is some evidence in the initial studies that was done by Masuoka Koga, where the patients were followed up for 30 years, and a 10-year survival was found to be better in patients who had all the thymic tissue resected instead of doing only a thymomectomy. So it was, the difference was in the range of 96% for extended thymectomy, and about 61% for patients who were only subjected to removing the thymoma, leaving the rest of the thymic tissue. So these are the various approaches, and then for very large tumors, we can use clamshell thoracotomy, which is, if it is extending on both sides to access both the hemithoraces at the same time, we can do a clamshell thoracotomy as well. Now, the principles of VATS thymectomy, unilateral versus bilateral. This is a debate which has been going on. People believe that a unilateral thymectomy is enough to get the whole of the thymus out, but one of the complications, or especially if the patient has got myasthenia gravis, is the thymic rests. And these thymic rests are usually found in the aortopulmonary window or in the cardiophrenic angle on the left side, left hemithorax. So a unilateral approach right from the right, with the right VATS would not be able to clear these thymic rests satisfactorily. So there are many surgeons who routinely put a bilateral approach in order to get all the thymic tissue, as we have already mentioned. If there is any thymic tissue left behind, there can be some scenarios where the patient gets a thymic, the patient gets myasthenia symptoms later on. So a bilateral resection is advised, and a subxiphoid approach, which is a midline approach for so that we don't have to make so many cuts, 3 separate cuts on the right side and 3 separate cuts on the left. So a subxiphoid approach is also very convenient. However, it needs a more skill. It needs a different set of instruments which are much longer. Also it needs more skill from the assistant point of view. So I usually use a right-sided approach with 3 ports and carbon dioxide insufflation, which gives us a lot of room to operate, and to avoid seeding of the tumor, I always use a retrieval bag. And if I were using a bilateral approach, I would be dissecting out on the right side, and then going to the left, getting the retrieval bag on the left side and taking it out. I must say it's a little bit more cumbersome on the with the retrieval bag on the left side, because the size of because the heart, the space on the left side is much lesser than what is on the right. It's more convenient working on the right. There is another reason why a right-sided approach is more popular with the surgeons, is because on the right side we can clearly see the phrenic nerve and the brachiocephalic vein, and the thymic branches, which are usually the branches that bleed and result in an opening, a conversion to an open case. But on the left side, it is more difficult, and there is more injury to the brachiocephalic vein, starting from the left side and doing the whole operation from the left. We need to keep in mind as well, when we're doing bilateral, we have already opened the right side and we're going to the left. So CO2 insufflation doesn't work very well. So might have to close the right side, put a drain in, and then go to the left for CO2 insufflation. The principles should be same as in open. Phrenic to phrenic, all the tissue gets removed, and from the brachiocephalic vein to the diaphragm. So as I already mentioned, thymic rests are in the aortopulmonary window, and as a result. So this is a short video. It's a 2-minute video. I will move it along. So it's an approach from the right side. You can clearly see the phrenic nerve there, and in this clip you can see the aorta, the brachiocephalic vein at the top there. With a little bit of blunt dissection and the harmonic, I use a harmonic. Some people prefer to use ligature, but whichever kind of energy device. I usually put in 3 ports. One of them is a 10mm port, which is in the 5th intercostal space, mid-axillary line, and 2 other 5mm ports, one in the anterior axillary line, 5th intercostal space, and one in the 3rd intercostal space, mid-axillary line. Basically, minimum trauma, 5mm ports, just for the instruments, the harmonic and the grabber, and the camera through the 10mm port, and with CO2 insufflation. So moving this along a little bit, after dissecting from the right side, this was a lady, a young lady, 28-year-old, who had, again, recurrent infections. I tested her for granulocytosis or any autoimmune disease, but she did not have any of the syndromes. She just presented with recurrent infections. She had a CT scan of the chest. She was found to have a hypoplastic thymus, and there was some doubt whether there was a thymoma. After resection, she was found to have a small 1.2 centimeter thymoma in the thymic gland. Now, okay. Moving along. This is where we started. Contraindications for minimally invasive surgery. If the patient has got substantial pleural and pericardial lesions, as we said, the aim is to have the same results with a sternal approach as transsternal approach as with minimally invasive. So if there is substantial pleural or pericardial adhesions, we wouldn't be doing minimally invasive. Great vessel or pericardial invasion, including the innominate, or if the some surgeons prefer not to do a minimally invasive procedure if the tumor diameter is more than 5 centimeters. So because invariably it is adherent to one of the structures in the mediastinum, and R0 is the aim of surgery. So it has been found that stage 3 and stage 4, there are 7.5 times more likely to be converted to an open. So basically stage 1, stage 2 are the ideal cases for a minimally invasive surgery. Robotics might extend some of these indications because of better vision, wristed instruments, better resolution. We might be able to do some more extended robotic surgery and probably push the boundaries a little bit. Also, if we have put a needle preoperatively, and the type of tumor cells, if they are B3 or C would be thymic carcinoma, but even if it is B3, it generally tends to be more aggressive and involving the capsule or invading the capsule and surrounding structures. So it is advisable not to start the case as a minimally invasive. Looking at the prognosis of thymic tumors, this is a paper from China, which has shown that based on the WHO histology groups, low risk, intermediate, and the high risk, needless to say, low to high, the disease-free survival keeps decreasing, and the Masoka stages, the higher the stage, the lesser the disease-free survival. Resection status, R0, is very important, and it drops as much as from 85% to 42% for R1 and R2 tumors. I just wanted to mention a couple of cases which I had personally come across. So not every tumor that is in the anterior mediastinum is a thymoma. This is a 59-year-old lady with vague pains in the anterior chest and had a mass 3.5 centimeter by 4.3 centimeter. And as you can clearly see from the scan and the X-ray, it is nearly screaming at us. It's a thymic tumor. So all the tumor markers were negative, and there was no signs of myasthenia gravis. Patient underwent surgery, right VATS, extended thymectomy because this was classed as a thymoma by the radiologist, and the histopathology showed a benign bronchogenic cyst, a very rare occurrence, but that's sometimes you get some other tumors in that location. Now, this is an interesting case. A lady, a 69-year-old lady, had an acute presentation with oculobulbar myasthenia gravis, slurring of speech, double vision, unable to swallow, and she was only living on puree diet for about a month or two when she presented to A&E with difficulty, double vision, and slurring of speech. So her difficulty to swallowing had started much earlier, and then now she was having slurring of speech and double vision. She was started on prednisolone 60 milligrams and then admitted as an inpatient because we didn't know how aggressively her myasthenia gravis was going to progress. So she was started on prednisolone 60 milligrams on alternate days, then increased to 100 milligrams alternate days till she got some stabilization of symptoms. Then she was discharged home, and in about 4 months' time, I saw her in clinic for surgery. and attempted to do VATS, as is clearly evident. Her BMI was very high, and she could not tolerate a single lung ventilation. She was desaturating on a single lung. So we had to do a median sternotomy and an extended thymectomy, wedge resection of the lung. So looking at the tumor, we would have thought that it would be a thymoma and it would be the lesser stages, but it turned out to be a B3 thymoma with Masoka stage 2A. And this was also involving the left lung. So she needed a wedge resection of that lung. This tumor, so this is the debate about the phrenic nerve and how you handle it when you're in theater. So this tumor was very close to the left phrenic nerve, and it was the adventitia was applied onto the left phrenic nerve, adherent. So we had to dissect it by diathermy, and as well as sharp dissection, and leave the phrenic nerve in place. And that was the site that came back as R1. So unfortunately, she did not get an R0 resection, but I had to make the decision to leave the phrenic nerve in, as she had suffered. She was suffering from myasthenia gravis, and sacrificing the phrenic nerve would mean that would compromise her breathing and could lead to postoperative complications. So we had to make that decision there. Now, she was referred on for adjuvant chemotherapy and radiotherapy. This is another interesting gentleman who, an 83-year-old gentleman who is generally fit and well, did not have any comorbidities as such, never had ischemic heart disease, stroke, renal problems, nothing, presented with severe shortness of breath, and his chest x-ray and his initial CT scan is the scan here, the lower right panel, where you can see that he had a massive pericardial effusion and bilateral pleural effusion, which was drained, and about 2 liters of drained pleural effusion and pericardial effusion, and then he recovered well. And then he had the scan, a repeat scan, which showed that he had a large mass in the anterior mediastinum, referred for biopsy initially, because they tried a needle biopsy, which was inconclusive. So we went in and did a hemisternotomy, partial sternotomy, and biopsy, which was reported as atypical thymic carcinoma, atypical thymoma type A. And even though we had a histological diagnosis, the CT scan and the MRI showed quite aggressive disease. The MRI did not show invasion of the pericardium or the heart. And so we decided to go in and remove the whole of the thymus from the anterior mediastinum. So underwent surgery, median sternotomy, and the tumor was involving not only the pericardium, so the pericardium was resected out, but part of the tumor was involving the RVOT and could not be resected, unless we put him on bypass and probably replaced with a graft and valve, probably pulmonary valve, which was a big undertaking for a gentleman, 83-year-old. So I shaved the tumor off the heart and put some clips there for future reference. Then the tumor came back again as R1, and patient was referred for chemoradiotherapy. In this case, it is very limited options he has got, because one, is 83 and he has got some element of heart failure, even though he did not present with that in the beginning. And I was told that he can't have radiotherapy because the radiotherapy would damage the myocardium of the heart. So looking at complications, major bleeding, vascular injury to aorta, SVC, left innominate, diaphragmatic injury, phrenic nerve damage, or sudden cardiac arrest. So operative mortality usually is less than 2%. In summary, thymoma is a rare disease. Myasthenia gravis is not an adverse prognostic indicator for thymoma. So the patient should go ahead with all treatment. But thymoma is a adverse prognostic indicator if in a patient with myasthenia gravis. So there is no common consensus regarding the extent of surgery, but as we said, the general surgical fraternity, we resect the whole of the thymus with the thymoma because of the initial papers which showed the two series, one of 200 patients and another of 89 patients where the extended thymectomy gave better results and then thymomectomy alone. So minimally invasive surgery is safe. It is the in thing. Everybody is doing minimally invasive surgery, but only if the full oncological principles are achieved and we can get an R0 resection, is it worthwhile doing minimally invasive. Now, TNM staging, and there is further data that is accumulated now, 7,100 cases, and there are some 2,000 cases waiting to be looked at, nearly 1,000 cases, 10,000 cases worldwide, which will provide evidence for treatment and follow-up of these tumors. Thank you.
Excellent talk, Dr. Lakshmi. So we are way beyond time. So I'll just take up two questions which have come up in the chat box. If it would be very useful if you could answer them. The first one was, is there any role for surgery in a patient with myasthenic crisis? Have you come across any situation where a patient is in myasthenic crisis
Yes, in myasthenia crisis, that is the type 5 of myasthenia gravis, patient is stuck on a ventilator, and over time they are not going to be able to get off the ventilator. And you start the steroids at that time because they can't have the other oral medications. So they get intravenous steroids, and if they do not improve on only with intravenous steroids, then we have to think about doing antibody titers. If the antibody titers are high, usually it is an arbitrary number of about 100. If it is more than 100, then we put them through plasmapheresis. So multiple plasmapheresis till the antibody titer comes below 100. Then do a thymectomy. And we had a patient like this, and that's why we are, I can say quite confidently that there is an indication for surgery in patients with myasthenic crisis.
That question is an excellent question. So what is your preference of lymph node dissection when you perform resectional surgery for a thymoma? Do you have any preference, and whom do you select to resect? What is your?
So if it is a thymoma and it is completely confined to the thymus gland, so I take the thymoma and the surrounding thymus with any lymph nodes, that is the perithymic lymph nodes, but the deep N2 lymph nodes, I go after them only for thymic carcinoma. So I have resected 2 cases of thymic carcinoma involving the pericardium and the surrounding tissue, the lung. So it was adherent to the lung as well as the pericardium. So resected the pericardium, reconstructed the pericardium, and went to all the lymph nodes around the trachea and took all of them. So these cases are few and far between because sometimes they are not well enough to go through surgery.
So as a message to the audience, any node that is seen on imaging, I think you should go after them. Is it?
Should go after them, yeah.
And then second, only in extensive cases, is there any role in B1, B2 if you know, if somebody comes to you with a biopsy of a B1 or a B3,
no. As we said, in thymomas, basically, stage 1 to resectable thymomas, basically, the earlier stages, it is only 2% of the cases have got lymph node metastasis. And so there isn't much value in doing the deeper lymph nodes, into lymph nodes, because there will be more damage to the structures. But the later stages of thymoma and the neuroendocrine tumors, there is as many as 27% have got lymph node metastasis. So we should be doing lymph node dissection in those patients. And these are the things that will be beaten out in the latest 10,000 patient database that is being created at present, for the next TNM. So this is the kind of information that we will gather, because all other papers are localized or from a particular country, but now we are going to have worldwide data.
Another important question: we all keep, bringing the patient to the multidisciplinary tumor boards, but the question is, what anatomical situations would make you pursue a non-surgical treatment for a patient with a thymic tumor? So you're in the tumor board, you're looking at a patient, and okay, you say, this, I will not go for surgery. Or go for some other induction or some kind of treatment.
So the I need to go back to the NCCN, the NCCN slides, where you have the resectable tumor and the non-resectable tumor. So you have got, if it is involving the arch of the aorta, you're not going to undertake surgery and replace the arch of the aorta. If it is involving the superior vena cava, yes. Brachiocephalic, yes. But if it is involving the arch of the aorta, if it is involving more than one structure, and maybe the PA. So we have resected. I have personally resected thymoma of the PA, and then recurrence involving the PA again, and go back and resect it a second time. Yeah. So if it is localized, if it is within a resectable limit, but if it is extensive involvement of the PA, extensive involvement of the arch, and multiple vessels are involved, then probably and this particular case that I mentioned, an 83-year-old man, at some point you got to stop resecting.
And this will be the last question.
I know we are all scalpel happy people, but yeah, we have to.
This is the last question. I think from one of Juliet colleagues, you put in a scope inside, and you see pleural seeding on entry. What do you do?
You got to come out. You got to sample it, obviously, and you got to come out and refer the patient for chemotherapy first. And once the chemotherapy has been given, look at the response from that. And then if the patient is resectable, so restage the patient. And if the patient is resectable, then we proceed with resection. If it is like a pleural, you said multiple nodules, so probably he won't be a resectable candidate, he or she won't be a resectable candidate.
So let me rephrase, 1 or 2.
1 or 2, yes. So 1 or 2, it can be resected out, but definitely give chemotherapy, then operate on the patient, and then follow up with further adjuvant radiotherapy and chemotherapy.
So thank you so much for giving this wonderful lecture. I'm sure that many people would have benefited from this. So we'll go on to the next speaker. This is Dr. Bhavesh Poladia, and he'll be speaking on how an oncologist can help a surgeon. Welcome, Dr. Bhavesh.
Thank you for the introduction, Dr. Sarvana. You able to see my slides?
Yes, sir.
Yes.
So good evening, and thank you for the opportunity. So I'll not be taking much time because majority thing has already been covered. So I'll be touching up on the radiotherapy and the chemotherapy aspect of it. So definitely, as already discussed, multidisciplinary approach is very, very important, especially when the stage is 2 and above for thymic tumor. So I'll be talking about that. I'm Dr. Bhavesh Palladia, medical oncologist from Thangam Hospital, Thangam Cancer Center, Namakkal, Tamil Nadu. So outline will be very, very brief. A small introduction. I think most of it has been discussed. What is the need of multidisciplinary approach? Surgery, already it is covered in detail, so I'm not going that. A part of radiotherapy, what are the doses? Chemotherapy, palliative therapy, and newer approaches. So as we have already seen, majority of the patients are going to be in first stage. Very small will be in second, third, and fourth stage. So the major role is for the surgery, which has already been discussed. So as already mentioned, anterior mediastinal mass, either symptomatic or asymptomatic. The common differentials are either neoplastic, non-neoplastic. When we consider the thymic tumors, constitutes to almost more than 50% of them. Others are lymphoma, germ cell tumor, lung metastasis. Obviously, biopsy has to be required. Biopsy is required for that, and the treatment is absolutely different compared to what the thymic tumor requires. There are certain other non-neoplastic entities, intrathoracic goiters, thymic cyst, lymphoangiomas, and aortic aneurysms. Definitely, it requires a separate treatment. Initial imaging and tumor markers help us to differentiate and to find out whether the tumor is most likely to be thymic. So a well-defined anterior mediastinal mass in the thymic bed with absence of continuity with the thyroid gland and absence of any other lymphadenopathy and tumor markers negative. This would be an ideal scenario where we think that thymic tumor is a likely condition. So very subtle difference between thymoma and thymic tumor, which you can see clinically. So if we see thymoma, the age is usually 40 to 70 years, whereas in thymic carcinoma, the age range is quite wider. The race, if we see, thymoma is more common in African Americans, Asians, and Pacific Islanders, whereas in Caucasians, you see more of thymic carcinomas. The paraneoplastic syndrome is usually associated with thymoma almost 30 to 50% of the time, and it is rarely associated with thymic carcinoma. So usually when there is thymic carcinoma with myasthenia gravis, we actually go back and recheck or double check the thing. So thymic tumors are the most common anterior mediastinal tumor, but definitely they are rare. If we see the overall tumors, there's hardly 1 or 2 cases per million, but has a very good survival with a good surgery. So thymoma accounts to almost 5 years survival to 90%, and thymic carcinoma, the 5 year survival is anywhere between 50 to 60%. So the classification has already been discussed. The WHO histological classification 2015. Masoka Koga clinical staging 2011, and the latest AJCC prognostic group 2017. So the management, in the management, the most important is the staging and the extent of resection, which will dictate the outcome and the prognosis. So that's why a multidisciplinary team is very, very important, starting with the radiologist, which will find out the anterior mediastinal mass, followed by a thoracic surgeon who will decide whether it is resectable or not. And after resection, the pathologist will give us the resection margin, whether R0, R1, R2. And followed by that comes the role of adjuvant therapy in the form of radiation oncologist, medical oncologist, and definitely not to forget the neurologist who, when myasthenia crisis or myasthenia gravis has to be controlled, even before surgery, during and after surgery. So neurologist has an important role in that. Biopsy already been discussed. Bone needle or open biopsy is recommended, and avoid any transpleural approach. It is usually recommended only for locally advanced or unresectable cases. If the surgeon feels that it will come out, the resection is going to be helpful. There is no biopsy which is recommended, and a total thymectomy and complete surgical excision of tumor is done, either open or minimal invasive. So what is the role of radiotherapy? So if we see, it is a very small role. And in a completely resected R0 stage 1 with no capsular invasion on pathological post-op pathology, there is no role of adjuvant therapy, neither radiotherapy nor chemotherapy, and hence none of the adjuvant therapy is recommended, and surgery itself is the cure for the patient. But if we come to the stage 2 to 4, even if there is an R0 resection done, but the final post-op HPR shows capsular invasion, these are the candidates who will require an adjuvant radiotherapy. So here, if we see the R0 resection, R1 resection, and R2. So R0 is a complete resection. R1 resection will have microscopic, and R2 will have macroscopic involvement. So the dose of radiation changes with the amount of resection. So it's a minimal R0 resection, 45 to 50 gray is recommended. With R1 resection, at least 54 gray, and with R2 resection, definitely 60 to 70 gray. Sometimes it is also required to give adjuvant chemoradiotherapy, that is chemotherapy and radiotherapy together. Ideally, this radiotherapy is given at 1.8 to 2 gray per fraction, and the total dose is achieved as maximum as possible. So radiotherapy is also used in locally advanced or recurrent diseases, especially when neoadjuvant or an induction therapy is done and a patient goes for surgery. This patient will definitely require radiotherapy after surgery. Also, in a solitary met or a metastasis or a ipsilateral pleural mets, post-surgery, this patient would definitely require radiotherapy. And this group of patients will require full radiation in the form of 60 to 70 gray for the complete dose. So there are the entity I have already mentioned. There will be certain areas where there is a use of concurrent chemoradiotherapy, where locally advanced unresectable disease is there, or a disease which post-induction deemed unresectable. So even after an induction therapy, the surgeon feels that the resection is not possible and the patient will remain unresectable. This is the place where concurrent chemoradiotherapy will have some role. We will not have any phase 3 or a randomized control in thymic tumors. Most of them are phase 2 data, or most of them are case reports, case series. Also, role of palliative radiotherapy should not be minimized. Definitely, there are various options which are there, starting with just 8 gray single fraction, or 20 gray 5 fractions, and 30 gray over 10 fractions, or sometimes even a full dose of 60 to 70 gray is given for a symptomatic benefit, for the symptomatic benefit. So various radiotherapy modalities are there, and it is preferred that minimum a 3D CRT is offered. Definitely, there is an option or betterment to do a 4D CRT or IMRT. Proton therapy is also indicated in this condition, where it gives minimal damage to the surrounding structure because of the strategic position of the tumor. And definitely SPRT also has a role when you have a very select or a very single met to be addressed. Coming to the neoadjuvant and the adjuvant chemotherapy. So usually a neoadjuvant chemotherapy is advised when there is a potentially resectable tumor and surgeon wants to downsize the tumor and then go ahead for the surgery. There are 4 or 5 trials which have seen that, but there is not much major change in the overall survival. The overall survival almost remains same whether we do a neoadjuvant followed by surgery or an upfront surgery. Numerically, a little better to go with neoadjuvant followed by surgery. So these are usually potentially resectable or locally advanced cases where neoadjuvant therapy helps. Ideally, usually a preferred chemotherapy is Pacli plus carboplatin, or a CAP, that's cisplatin, adriamycin, and cyclophosphamide, or addition of vincristine to CAP. Many a times when we see that this is a neuroendocrine tumor, a cisplatin etoposide does a equally good role. This was all about the curative setting, and if we can, sorry. So if we can come to which is a very small stage 4 tumor, which is will require palliative chemotherapy. So there is a very slight difference between thymoma and thymic carcinoma. There are 6 different combinations which are usually preferred, and out of that, the most preferred is the CAP, which is cisplatin, adriamycin, and cyclophosphamide. The reason behind that the maximum response rates are seen with this regimen, almost to the tune of 44%. But if patient is not fit for an anthracycline or adriamycin based therapy, then there are certain other options which can still be tried, like a cisplatin etoposide or with or without ifosfamide, and definitely paclitaxel carboplatin is also a safer and a better option. When the thymoma they have progressed on first line of therapy, there are multiple choices we have in the second line. Most of them have a response rate between 15 to 40%. Pemetrexed, everolimus, paclitaxel, gemcitabine plus minus capecitabine, 5-FU-leucovorin, etoposide or ifosfamide can be used. This patient sometimes have this thing will be also benefited by long-acting octreotide plus minus prednisone. Point to be noted is in thymoma, usually pembrolizumab is not recommended. A phase 2 trial was done to see this, and they saw that almost 9 to 10% patient have severe autoimmune myocarditis, which led to death of the patients, and that's why pembrolizumab is not recommended. Again, sunitinib, again, there is hardly thymoma will have c-KIT mutations, and that's why sunitinib is not recommended for thymoma. Coming to the thymic carcinoma, again, CAP ad hoc is a good regimen, but a preferred regimen here is paclitaxel and carboplatin, and response rates are up to the tune of almost 35 to 40%. Coming to the second line, it is almost similar like thymoma, but with the addition of a few other drugs like pembrolizumab, S1, lenvatinib, which is not studied, which is not benefiting thymoma. Even the pembrolizumab, which was not doing good in thymoma, has done comparatively better in thymic carcinoma. Almost a response rate of around 22 to 25% is seen with that. So the response rate ranges with the second line anywhere between 4 to 21%. So we'll not, and I'll just share some Indian experience. Starting from the first of the papers on thymic carcinomas was from Tata Memorial Group in 2014. It was a compilation of 62 patients, and they found that all stage median overall survival was roughly around 60 months, and a 3-year overall survival was 90%. Similarly, recently 3 years back published, 2018 by V. Tirumala et al. It was a case series of 24 patients, and their ad hoc was the preferred regimen. They have seen the stage 3, the PFS, 2-year PFS was in the tune of 75%, and the overall survival was with the tune of 82%. Similarly, when the stage was advanced, that is the form of stage 4, the PFS came down to 40% and overall survival came down to just 60% at the end of 2 years. One more paper in 2018 published by K.C. Lakshmaya et al. It was a series of around 49 patients, and these were all purely stage 4 patients, which showed a median PFS of 11 months and overall survival of just 20 months. So we can see this is a small subset, stage 3 and stage 4, which are usually not resectable, and they will go for this palliative kind of a therapy, but still there is a role of chemotherapy which helps them to live for longer, for 2 years, 3 years, and sometimes even 5 years. So there are other palliative chemotherapies which are also available. Recently, one medication, it's a case report from China where enlotinib was used almost post 5 lines of therapy, and patient did show response to this medication. There are other combinations which are used like cisplatin, irinotecan, capecitabine, celecoxib. And beyond chemotherapy, this targeted therapies have been explored in the form of EGFR inhibitors, cetuximab, geftinib, and erlotinib, KIT inhibitors, imatinib, multi-kinase inhibitors like sorafenib, IGFR inhibitors like pigitubumab and sixitubumab, and VEGF inhibitors like bevacizumab alone or with erlotinib. So these are the other things which have been seen. We have for certain case reports and phase 1 or 2 studies on this. And there are certain approaches in the pipeline where they are combining chemotherapy with VEGF inhibitors like paclitaxel plus carboplatin plus or minus ramucirumab. Also, a combination of pembrolizumab with another chemotherapy agent or a targeted agent is been seen. Avelumab, selinexor and bintrafusp alpha. There are other new drugs which are in the pipeline, and probably in few years we will have the outcomes of that, whether they are and these are usually second line and beyond. So we'll have more drugs in our armamentarium to deal with these tumors. So thank you for the patient listening. This is our hospital. This is my team. And thank you for the patient listening, and I leave you with positive thoughts. Sarvana, you're muted. You have to unmute. Sarvana.
Thank you, Bhavesh, for your excellent lecture. Always, up to the point and very concise. So, what do we have next, Dr. Lakshmi? We have a case for discussion. Do we have it? You're on mute.
I'm on mute. Yeah, I have presented my 2 cases.
Okay.
Unless you want to bring up a scenario, and we can discuss how we proceed with that case.
Bhavesh, anything you want to ask?
So any cases from your MDT or anything you want to choose, and we can discuss what you would have done and what we would do.
Okay. So we've had certain a situation where we had a 60-year-old female who came with myasthenic symptoms, new onset, with oculobulbar palsy. And then what happened was she went on, she had to be intubated. She was ventilated for 3 days. She was given immunoglobulins, and on day 6, the intensivist had requested a tracheostomy, and I had performed a tracheostomy on the patient. We started him on plasmapheresis, and still no improvement. But the CT scan showed a resectable thymic lesion and with a right paratracheal node. So the request from the neurologist was, can you go in and do a desperate surgery for this patient? The patient is already ventilated. Why not go in and resect it out? So what would you have done in this situation? So I will tell you what I did, and I'll ask you, there were decisions I had to make even during the surgery. So how would you proceed with this?
So there was a mass in the antemediastinum.
Yeah, it was not huge. It was just a 3 into 4 centimeter mass with a 1 into 2 centimeter right paratracheal node in level 4R and 4R station, and that was it.
So the fact that there was a lymph node in 4R station, that kind of tells me that this probably is not straightforward stage 1 or early stage 2 Masoka staging. So I would have tried to get some tissue first. So get some CT guided tissue and see if there is any other form of treatment that we can offer her. And so I don't know what Dr. Palladia will think, but radiotherapy is very difficult to do when patient is intubated, and chemotherapy is the only other thing that we can think of. So of that, I would have to defer to Dr. Palladia to ask him what kind of chemotherapy he can even offer this patient. So that is an option. The other one would be, because the patient is already intubated, and when patient gets a myasthenic crisis, they get respiratory paralysis and then need intubation. So if the patient is already intubated, we can go ahead with surgery and then give chemotherapy. That is the second option that we can also go into. So, depending upon how much inotropes the patient is on, what is the other status of the patient other than this problem. We'll have to make that decision.
So this patient went on to have resection because the oncologist was not, Bhavesh was not there. So the oncologist was not very happy to give chemotherapy to a patient who was ventilated and intubated and who was 60 plus with diabetes and COPD as well. So the neurologist, the family had a discussion with the neurologist. The neurologist was persistent in telling me that, why don't you just get it out? Go for it, and took it out. Surprisingly, what happened is we took it out and it came out to be a B3 tumor with the 3 lymph nodes in the right paratracheal region. And then the patient started responding. So he had 3 plasmapheresis sessions prior to surgery, one plasma, and then surgery, and then went on to have another 2. And after that, after a total of 5, pre 3 and post 2, the patient started showing signs of muscular improvement of muscle tone and muscle thing, and she started breathing. Of course, she stayed on the ventilator for another 12 to 13 days and stayed in the hospital for 40 days, but eventually she came out. And the lesson I learned here is that, in an elderly patient who has a new onset, especially those who are above 45, and I've seen this time and again, an elderly patient above 45 who's having new onset symptoms of myasthenia, I think, these patients usually have, a rough post-operative course. Otherwise, thymomas usually, they're straightforward operations, and you don't talk about morbidity or mortality in these patients. What has been your experience?
So similar to your experience, the patient presented in myasthenic crisis, intubated, ventilated, and high titers, like running into to our 200s. So we had to do plasmapheresis, bring down the titers, and then we operated when the patient was under had the ET tube still in place. Then she extubated afterwards. So it was day 3 after surgery. She was well enough to extubate, but obviously went on to CPAP and had to stay in hospital for a long time and did not go out of hospital nearly for a month. But eventually, the process for her was she was only a B1 thymoma, but she had her thymoma stuck to the left phrenic nerve. So even though we removed everything else and we didn't want to sacrifice the phrenic nerve because she's already stuck on a ventilator, if we sacrifice the phrenic nerve, she may never come off the ventilator. Young lady, hardly 29 years of age. So we left the phrenic nerve in place and left some clips, etc. She got her radiotherapy, she got her chemotherapy, but then after 7 years, she had a recurrence. And they had to be treated by chemotherapy again because it was exactly at the spot of the phrenic nerve. So it was a question of sacrificing the phrenic nerve. Do we want to do it now that she is 35 years of age? Otherwise, she was well, and she's still fine now.
You resected again?
No. They said that no, it was stuck to the phrenic nerve. That is the only spot it recurred. Everything else was gone. So it was just that spot. So there was a discussion whether we should or we shouldn't. And a young patient, we can placate the diaphragm, but then it is a comorbidity. So they said, let us give another, treat that with chemotherapy and see if she will respond to it. And if it is increasing in size, then you go inside and resect it out. But if it doesn't and it responds some way, stays stable at least, then we leave it alone and follow it up. And because follow-up is generally quite good in European countries, especially UK. So we can afford to sit on these patients like that, and they will come back, and MDT will keep an eye on them and take it from there.
Okay. Next technical question. This is a surgical question, so I've encountered this issue also. You come into surgery, you have a non-myasthenic patient with a thymic tumor, and now you are, it's stuck to the phrenic.
It's stuck to the phrenic.
Yeah, non-myasthenic, young patient, 45 to, I think, 45 years of age, stuck to the phrenic. R0 will be achieved if you get the phrenic out. What would you do? Would you resect phrenic? Number one, would you placate the diaphragm and in the same sitting once you resect the phrenic? What is your view on this?
This is a highly debated topic in all circles. Okay, so if it is one phrenic, we can resect that phrenic on that side, and especially if it is on the left side, we can placate the diaphragm. So the right side is, in my personal experience, I don't know whether unless I look it up in the literature, the right side they struggle more. I don't know why. Maybe it's 55%, 45%. But if it is a right phrenic goes, they struggle more. If the left phrenic goes, they kind of like and placate the diaphragm. kind of works all right. So plicating the diaphragm, if you're doing a sternotomy, median sternotomy, is a difficult undertaking, especially on the left side. So I would leave it and go after the diaphragm on
another day.
Another day, different setting. Yeah, because of the difficulty and the fact that obviously we've done the thymoma. Let us see how the diaphragm behaves. Like if it needs plication, we go in and plicate it later on.
I think we had any other questions. Would you like to ask us or something? Nothing. I think the message should go that, if you're operating on a myasthenic patient, be very wary of using energy device very close to the phrenic, because it will make a huge morbidity for the patient, and you might end up even losing the case, because any injury to a phrenic with a patient who's myasthenic, is literally a difficult situation in the post-op period, because these are patients who actually do well even with adjuvant, so you can get away with the R+ resection still and do some adjuvant treatment for them rather than cut the phrenic and make the patient suffer.
I have the same question for you. What would you have done with that diaphragm where the phrenic nerve was sacrificed? Would you go for the same setting or different setting?
No, I have encountered this situation in 2 occasions where I was doing VATS and I electively, elected to resect the phrenic. And in VATS, it's a little forgiving, I feel. So because you're going from the, it's easy to perform. But so this was one patient on the right side. I was able to do the plication using extracorporeal, knotting technique and getting it done. Whereas on the left side, I had to position the patient again to lateral and put another 2 more ports to get the plication done. So I did plication on both instances. Yeah, however, like you said, in no open case have I ever considered plicating the diaphragm.
It's very difficult.
Yeah, it's really difficult to do, and I usually do not do the same. One more question, which I just got it on my mobile through one of the colleagues is, okay, if a patient has had myasthenia, you resected, you did a proper resection, and the patient has a recurrence of symptoms, is there any role for resurgery? Would you image the patient to look at any blind spots that has been left behind? Is there any way to go back in, or do you usually not go back in? For the 1/3 of the patients who do not respond.
Yes, so that is why if we have pre-surgical diagnosis of myasthenia, I take extra care to go into both the pleurae, right to the cardiophrenic angles, take everything out, literally only leave the phrenic nerve lying there, and back up right into the neck, beyond the brachiocephalic, around the branches of the aorta, and trace everything that can be seen, so that to avoid this scenario. So if the patient has got a no response, or either minimal response, or continues to have myasthenic symptoms, there's not a whole lot you can do from this point of view. So that lays this topic to rest, that everything has come out, and there is no thymic rest, there is no, so there are different people. I have worked with a lot of mentors, and sometimes they say that, oh, you only want to remove the thymus, so why removing the fat and leave the fat behind? But there can be sometimes thymic rests in this fat. And I said aortopulmonary window, or in the cardiophrenic angle. So that needs to come out. Everything needs to come out if it's myasthenia gravis. And then you are assured that you have done the job, and the patient needs medication afterwards.
So I think we have had a good session, and so to summarize, surgically thymic tumors are very resectable, very much resectable, and there's a high potential of cure if you get the tumor out early with proper oncological, principles. The second thing we learned was surgery in myasthenia gravis is more extensive than surgery for a pure non-myasthenic thymoma. You have to be absolutely, you have to take out radically all the thymic tissue as well as fat, and be wary of injury to the phrenic. nerve. And then another thing, which was a good point that was alluded here, was however advanced thymic tumors are, except for a very few situations, most of them are potentially resectable, and hence you will have a better outcome if you have an R0 or even an R1 resection. So I think surgeons should be more aggressive in treating these tumors and not shy away from doing aggressive surgery. So there's very little of situations where you will not go in and resect those patients. And another thing is, right now, most guidelines suggest that any stage above 2 and or an R plus resection requires some form of adjuvant treatment, and a multidisciplinary tumor board meeting and discussion is required among various specialties for the best interest of the patient. I thank Dr. Lakshmi, Dr. Bhavesh for giving excellent lectures from your part, and Meryl again for helping us getting this good topic into the audience. Again, thank you.
Thanks very much. Thank you for having me. I thoroughly enjoyed the whole session.
Thank you so much, surgeons. It was an excellent session. Now, from our side, we would just like to do a small vote of thanks by my colleagues in India. Over to you guys, Nico and Subhajit.
Nico's gone.
You there?
Nico's gone.
Subhajit, unmute yourself.
Yeah, can you unmute yourself? I'm here, sir.
Hi, Nico.
Yes, go ahead.
So, honorable and respected faculties, Dr. Bhavesh, Paladia, Ms. Lakshmi, Srinivasan, and Dr. Sarvana. Ladies and gentlemen, it is my privilege to offer thanks on this occasion. I am Shubhajit Awan and entire team of MES family. We express our gratitude and thank you so much for the faculties here for their time and sharing all the valuable information, findings and opinions on thymic tumors management, which was very insightful. I am sure it was an academic feast for the viewers. Also, thanks to all viewers and one Meryl team to make this informative webinar possible on thymic tumor management. Thank you so much and stay safe for healthier tomorrow. Thank you very much. Thank you.
Thank you.
Thank you all.